I want to show you how to answer questions, even if you have no idea. Just make sure you don't get trapped. Just use the concept to answer the question. When you study, master the concept. Don't memorize it. When you see a question, don't jump the gun. Use the concept. Look at what they've given you. Don't bring in any more information and answer the question. This is one question. It's a straightforward question, but it's just one concept. When you write the concept down, you see that it's easy. Which of the following medication the nurse should question during medication reconciliation? The key word, the buzzword, is question. There's one medication on this list you should question when you're doing medication reconciliation. What is the concept? Straightforward. A nurse is caring for a client, a 75-year-old client who has what? Parkinson disease. Patient is admitted for pneumonia. Which of the following medication the nurse should question? I've underlined the buzzword. Those are the things you should focus on. A 75-year-old Parkinson patient is on a bunch of medication, and you want to know which one you should question. The pneumonia is irrelevant. Don't worry about it. Don't look at the answer's choice. Look at the question and say, hey, what is the problem? 75-year-old Parkinson is on some medication. Which one should you question when you're doing medication reconciliation? Before you answer the question, think about it. Parkinson patient, what do I know? Before you jump and answer the question. If you don't figure out what is a Parkinson patient, you're just guessing and wasting your time. Spend time and say, what should the board want me to know about Parkinson patient in terms of medication? Go to the pathophysiology. What is the pathophysiology for Parkinson patient? Low level of dopamine, right? And they have a bunch of acetylcholine. And therefore, what we want to do is to provide them more dopamine and then destroy the acetylcholine. That's all. This is their problem. That is the concept. Every time you see a Parkinson question, this is all you need. Why do they move like the way they move? It's because of dopamine. They're lacking dopamine. Why are they behaving like that? It's because of excessive production of acetylcholine. Concept. And when you take this, you look at the question and said, I have a Parkinson patient. I should make sure the dopamine is enough or high enough to be able to function. And that is the work we do when we treat patients with Parkinson. We don't do anything. We block the acetylcholine and give them more what? Dopamine to work with. Therefore, if you are the nurse and you're looking at this question, answer choices, which one should you question? And that is where you bring your content. You see, I went for the ask of the question the medication. What is the case, a Parkinson patient, the buzzword, I need to question that medication. Content needed, Parkinson patient should have normal dopamine to be able to function and decrease the acetylcholine to prevent the side effect of their condition. Then you tackle each one of the answer choice with that content. You take selegiline. I know you've heard about it before. You know what selegiline is. You should be able to figure it out by now. What do you think selegiline is? You should know that. It's monoamine inhibitor oxidase. What did they do? They block what? Monoamines. So monoamines are what? Norepinephrine, right? Dopamine and serotonin. They're going to increase this level. That is why they are very dangerous when you use them for what? Depression. This is what they do, right? This is what they do, right? So what do you think? What do you think this thing? They prevent the breakdown of these enzymes, these neurotransmitters, by blocking the enzyme that break them down. So when I give you monoamine inhibitor oxidase, your level of norepinephrine, dopamine, serotonin is going to go up. Do you think this patient will not be happy with that? Yes, of course. It's going to be happy for giving them what? Monoamine oxidase inhibitor. Therefore, this, you don't need to question it. This is good for Parkinson patient. You can use it for Parkinson. How about this? Pistol. Even if you don't know what it is, leave it behind. Let's leave it behind and keep on going. You see this? I told you we need to increase the dopamine level, right? For the Parkinson to be happy. I see levodopa, there is what? Dopamine there. Therefore, if I give a patient who has Parkinson levodopa, it's going to high five me and said, thank you very much. I'm doing fine. You don't need to question this. You don't know number 2. Assuming you don't know what number 2 is, leave it behind. Go to number 3 and see if you see something wrong with it. This is how you take this. You don't just boil down on things that will be disturbing you. I have no idea what number 2 is. Just leave it. See number 3 and see if you have any qualm about it. What is allopurinol? Second generation. No, it's a first generation antipsychotic. What did they do? What does a first generation antipsychotic do? How did they treat patients with schizophrenia? Every time you watch my videos, I try to give you, I don't just give you words, I try to let you understand the concept so they become easy. What does first generation antipsychotic do? They block what? Dopamine effect. And this is how they're able to treat schizophrenia patient, the maniac patient, all those things. They do this by blocking the effect of dopamine. Second generation block serotonin. That's why we use them in psychotic problem. All the maniac and all the side effect of hallucination from schizophrenic patient is because they block dopamine. And what is our problem? We should not touch dopamine. If you touch dopamine, you are in trouble for Parkinson. Therefore, which one is your right answer? You don't know number 2, but you see that you're able to answer the question by going down. Those that you don't know, just let it stand and see if you can find something that is obviously wrong. Allopurinol should not be given to a patient who has Parkinson's disease because it's going to block dopamine. And if we block dopamine, it's really bad for them. Number 1 increases dopamine. Number 3, levodopa increases dopamine. Number 2, if you don't know, is a dopamine agonist. Therefore, we're going to have high dopamine for that. Therefore, number 3 should be questioned. This is your right answer. This is how you answer question. You have no clue. You have no idea, but you'll be able to answer it. Expect to see the board do that. You have never seen the medication before. You've never seen anything like that. But what did I do? I go back to the pathophysiology. I said, Parkinson patient, hey, my dopamine should be high. And I should decrease acetylcholine. And I look at the answers. I say, I'm able to recognize 2 of them, and 1 is obviously wrong. Therefore, my right answer, it should be allopurinol. Parkinson patient should not do that. So that is the way you answer questions. Don't struggle too much. Memorize anything. Just know your concept. You can answer any question they will give you if you go back to the pathophysiology of the question. Same thing. A long question just to distract you. But I intentionally did this. What medication the nurse should anticipate to be given? So you're looking for medication to be given. What is the case? This is like a full case. This is what they will try to give you, even 20 lines to deceive you. But look at it carefully. Read between the lines. Pay attention. Don't be distracted. Keep on looking for the buzzword. We have a 45-year-old. He presents to the emergency room with what? Acute appendicitis. Patient has a history. You see, I told you, history of what? Schizophrenia. And he's taking what? Haloperidol. Okay. Patient underwent uncomplicated laparoscopic appendectomy. That means we removed the appendix. He was continuing on his home medication after surgery. He continued with his haloperidol. 12 hours later, post-surgery, the patient is diaphoretic, poorly arousable to verbal command, tachycardic, low-grade fever, hypertensive. What medication you want to give? Don't be distracted. Just find the buzzword. Let me summarize this for you using the buzzword. I just have a 45-year-old patient who has schizophrenia. He takes haloperidol, had surgery for appendicitis. 12 hours later, diaphoretic, poorly arousable to command, tachycardic, hypertensive, low-grade fever. What do you think the board is telling you? If I don't give you any more symptoms, that means you don't need it. So don't extrapolate. This is the symptoms the board wants you to pay attention to. I want you to pay attention to what? Diaphoretic, poorly arousable to verbal command, tachycardic, low-grade fever, blood pressure, hypertensive, and the patient had just what? He has just what? He has just what? Surgery. He just had surgery. Just had surgery. What do you think is going on with this patient? Do you think you need to give the patient dantrolene, cyproheptadine, benztropine, lorazepam? Don't pick an answer choice until you figure out what the patient is suffering from. If you don't know what he's suffering from, then you can't answer. You'll be guessing. You'll be guessing, get it right. But try and figure out what the patient is suffering from. And if you can't figure out, look at the answer that I've given you. Let's say which one and see if it's consistent with the problem. Do you think we should give them dantrolene or cyproheptadine, benztropine, haloperidol, and lorazepam? Concept, right? What do you think? This patient is 45-year-old, already has schizophrenia, taking haloperidol, just had surgery, and all of the sudden is diaphoretic, poorly arousable to verbal command, tachycardic, and that. If you can figure out, look at it. Dantrolene, what is it used for? It's a calcium blocker. It prevents release of calcium. If it prevents release of calcium, right, why do we use it? We use it for NMS or malignant hyperthermia. If I want you to pay attention to malignant hyperthermia, what would I tell you? Rigidity. Their jaw will lock up. I will give you a temperature 103 to 105. Do you see a temperature there like that? There is no temperature consistent with that. What else would I tell you? This happened in the PACU or in the operating room. Did you see anything in the case that is related to that? No. Therefore, it cannot be dantrolene. Same thing, neuroleptic malignant syndrome. I have to give you a temperature of 103 to 105. I have to give you muscle rigidity. Okay. Even though the patient takes haloperidol, he's been taking it for all his life. He's going to have signs and symptoms of NMS is from the beginning. There's no way all of a sudden he's developing malignant hyperthermia or neuroleptic malignant syndrome. So therefore, it cannot be NMS. The temperature is too low. There is no muscle rigidity. That's the key word. That's what you have to focus on. For malignant hyperthermia, usually they have inhale anesthesia too. I never said anything about inhale anesthesia. This never happened in the PACU. There's no lockjaw. There's nothing like that. Therefore, dantrolene is gone. Cyproheptadine. This is used for serotonin syndrome. Serotonin syndrome. Chronic serotonin syndrome, this is what you use. Acute serotonin syndrome, you use lorazepam. But look at the question. There's nothing that tells you patient is on SSRI. Do you see any SSRI there? No. I've not combined any SSRI. At the same time, there's no GI symptoms. Nausea, vomit is very good for SSRI, serotonin syndrome. What else do you see? You see clunus, you see aporeflexia. You don't see that. The board never give you. Don't bring it in the question. There's not, if I want you to focus on it, I'll give you the reflexes is high and what? They have clunus, everything is going to go up. But there's no reflex problem. There's no SSRI. There's no serotonin derivative there. Therefore, this is gone. You see where I'm going through this is what you do in your head. You don't choose it, but you just say, okay, let me break down these questions, answers using the content I know. And you see that the answer will pop out easily. Benztropine, what is that? It's an anticholinergic. What condition do you use anticholinergic? Extrapyramidal side effect. And what is that? Acute dystonia, akinesia, what? Parkinsonism, and tardive dyskinesia. All these things you use benztropine. What is acute dystonia? They will talk about muscle cramp. There's nothing in the question that talk about muscle cramp. Akinesia, inner feeling of restlessness. There's nothing in the case that say that. Parkinsonism, do you see anything related to Parkinsonism? No. Tardive dyskinesia, smacking of their teeth, showing you their tongue, moving their head. There's nothing there. Therefore, these cannot be extrapyramidal side effect. There's taking strategy. You're happy to pick number 4. What is the problem? Do you think this patient, what condition give you that? After you have surgery, you have what? And it's 12 hours. You came to the hospital, 12 hours. You being in the hospital 12 hours, all of a sudden, tachycardia, hypertension, low-grade fever, diaphoretic, change in mental status. What condition do you know when you admit a patient within 12 hours, all of a sudden, they acting out? And then ready to treat it, you give them lorazepam. I do not want to give it to you because then I give out the answer choice. The board can do that. I left that one part off. But when they give you a case, patient come to the hospital, all of a sudden is what? Tachycardic, hypertensive, what? Diaphoretic, change in mental status, 12 hours from going. What do you think? What condition do you know is very common? You see it all the time. Patient present like that. I tried to trap you because I did not want to give you the way. I could have given you hallucination. I never give you hallucination so that I can give the answer choice away. But this is what you will see. What do you think this patient have? Alcohol withdrawal. So therefore, this patient needs lorazepam. But even if you don't know, you have no idea. You look at the case, you said, I don't think it's malignant hyperthermia. There's nothing that tells me neuroleptic malignant syndrome. There's nothing that say this is extrapyramidal side effect. Therefore, I got to take away number 1, number 2, number 3. There's nothing that tells me it's serotonin syndrome. I have to pick number 4. This is alcohol withdrawal syndrome. So pay attention when they give you a case. This is the way they like to present alcohol withdrawal. It's a little bit weird. You can't figure out, but pay attention. The time is your key. 12 hours after surgery, all of a sudden. So patient who's, yeah, sometimes they tell you they drink, sometimes they will not tell you. So any patient admitted to the hospital with acute change in mental status starting 12 hours later without any precipitating problem, think about alcohol withdrawal. They probably have been drinking every day, and then all of a sudden for 12 hours, they've not had alcohol. And that's why they're acting like that. But you can answer this question without not knowing me putting alcohol there or putting hallucination. I've given you everything. Diaphoretic, poorly arousable, change in mental status, tachycardia, low-grade fever. The fever giveaway. There's no way you will have neuroleptic malignant syndrome and your temperature is 101. Or malignant hyperthermia and your temperature is 101. And therefore, you can eliminate one. And then you can eliminate the rest of them because that's the same thing. Serotonin syndrome, there's no reflexes. I've not given you anything like that. So this video, like I said, answering questions, you have no clue what it is, but you can figure it out. Same thing. This is just straightforward. It's a case I put in the community chat. A couple of people get it right, but it's concept, right? And next, I just completed workshop on eating disorder. Which of the following the nurse should know as the main difference, keyword, between anorexia nervosa and bulimia when evaluating patient? Look, this eating disorder, there's no one that belongs to one, okay? It's a spectrum. Eating disorder, the big word is spectrum. Anorexia and nervosa, you can figure out who they are. But there's one thing you can use to figure it out. There's always one thing. So don't limit yourself. When they give you a case, there's only one word you'll be looking for, and that is the concept. The spectrum, but focus on the concept to figure out whether they are anorexic or they bulimic. Okay. Both of them, they have perception of what? Body image, meaning they don't like the way they look. Okay, they both have perception of body image, so they don't like the way they look at all. Then look at what I'm going to do. I'm going to answer the question if you have no idea. I know both of them can do what? Purge. So they're going to purge. I know they're going to do some purging, right? The pattern of purging does not matter. Whether you put your hand in your mouth or you take some medication, the pattern of purging does not matter. So they're going to purge. If you purging, you're going to have enema issue, dental problem. You see what I did? They both have distorted body image and they both can purge. They eat and purge the food out. Therefore, if you purging, you're going to have dental issue. Therefore, 3 will knock out number 2. If you have bad body image, you're going to try to purge so that you don't eat. If you're purging, you have enema issue. And you see, I've answered the question. I don't even have to go to number 4 just by using test-taking strategy, right? If I'm purging, my dentition is going to get poor. Once again, if you purging, you should have bad dentition. And therefore, there's no way you can pick this and say this is wrong. Both of them has to be wrong. Being is fine. And we know bulimia do it more than anorexia. But that should not be because half of the question answer choice is right. Therefore, this cannot be right. You see how you answer question. Now you're left with what? Number 4. And that is the concept. The definition of anorexia or bulimia is based on BMI. You can never have a normal BMI and be considered anorexic. You can never have overweight, BMI, and be considered anorexia. Bulimia, usually they have normal weight or they are overweight. That is the key. So I keep on saying concept, that's what I mean. Anorexia nervosa, BMI is less than 18.5. Bulimia, BMI is greater than 18.5. It has to be greater. It has to be greater than that. Either they are normal BMI or they are overweight. Therefore, the right answer is number 4. 3 questions, you're just answering them. You have no clue, but you're not guessing. You just try to use what they've given you using the concept. Like I said, try. The NCLEX is favorable if you don't just overguess yourself. The little basic nursing concept, that is what is anorexia and nervosa. If you're reading your textbook, you're watching video everywhere, try to figure out when whoever is presenting it, see if they're talking about one concept about it and just use that. The best way to understand the concept is find the difference whenever you're watching, even if it's hypertension, they have to tell you one thing you can stand your leg on and then branches out to everything, if it's pharmacology or anything like that, because you can't memorize everything. Eating disorder, the only thing you should know is what? What is the difference between anorexia and bulimia? It's body weight. Of course, all the signs and symptoms they're going to give you, it will be confusing to you. They're both going to have amenorrhea, right? They're going to have all those signs. They're going to have enamel problem, their dentition, their calluses on the back of their hand. If they give you, keep on selecting it. But one thing you can tell whether this patient is anorexic or bulimic is body weight, and body weight. This is Adapting class. Thank you for spending time with me. If you need more, check my website, subscribe, like this video, share it to your friends so that we can grow the channel. And you can join our membership, just a few dollars to support the channel. But thank you. I hope you enjoy it and all the best of luck. Good luck in your exams. Bye-bye.